and gentlemen. I'm Ashish Shah, GM Marketing Intas Pharmaceuticals Limited, and we welcome you all to this live and interesting webinar, yet another one on a very interesting topic, which is myelofibrosis causes and effects, brought to you by Mumbai Hematology Group and ably supported by Intas Oncology. First of all, we'd like to extend the festive greetings to all the doctors and the community who have logged in on the occasion of Ganesh Chaturthi, which just concluded, and the festival is ongoing. And may God Ganesha bless us all with all the happiness, prosperity, and good health. Would like to brief a little bit about Intas, that Intas is continuously striving to bring all the latest advances in the field of hematology. And we have witnessed in the form of MAPTAS, ROMI, and others, in the field of hematology. And with your guidance and support, we'll continuously bring many such advances in the near future. We are everyone aware of this gentleman. He is none other than Professor Dr. M.B. Agarwal sir. Needs no introduction. He's the program director for this series of webinar, and he's an institution in himself. And the field of hematology would be at a different level, would not have reached to this level had Professor M.B. Agarwal not been in hematology. So we owe a lot to Professor M.B. Agarwal sir. Dr. Amit Khurana, he has earned a lot in terms of the accolades, with a very disciplined approach of executing and filling into the shoes of Professor Dr. M.B. Agarwal sir. Continuously executing, coordinating weekly webinars is not everyone's cup of tea, but Dr. Amit Khurana sir is doing it fantastically, and we are sincerely grateful to you for ensuring that those weekly webinars of every Saturdays and Sundays are organized flawlessly, continuously, so hundreds of students and many young doctors are getting benefited. Thank you, sir. And Dr. Amit Khurana is the moderator of today's webinar, and we request sir to take it from here.
Thank you, Mr. Ashish, for that kind words. Let me share the screen. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Debdat Basu from Pondicherry, and he's going to lecture us on myelofibrosis, causes and effects. This webinar, as usual, is brought to by Mumbai Hematology Group, supported by Intas, and very well managed by Perfect Square. I thank Mr. Arun Hegde, Dr. Manoj Kumar and the team from Intas, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Debdat Basu from Pondicherry, all our discussants who are themselves very eminent hematologists as well as hematopathologists, you participants for spending your Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 31st of August 2025 from 11:30 a.m. Indian Standard Time, we have Dr. Satish Kumar from Bangalore speaking to us on an update on ADC and bispecifics-based treatment of lymphomas, update from ICML and EHA 2025. Let me introduce our discussants for the day, and there are a galaxy of them here displayed in alphabetical order. I will pause for a while for you to have a look on all our discussants from the day across the country. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day, Dr. Debdat Basu from Pondicherry. He does not require any introduction. He has been our regular speaker, and when he speaks, When he gives a lecture, every information goes directly into our brain. That was Dr. Debdat Basu is, and again he is there today. And it's my formal duty to introduce Dr. Debdat Basu sir. Once again, Dr. Debdat Basu sir is Professor of Pathology at Mahatma Gandhi Medical College and Research Institute, Pondicherry. He did his MBBS way back in 1985 from Maulana Azad Medical College, Delhi, followed by MD in Pathology in 1990, again from the same institute. He is also the former professor and head of pathology at JIPMER Pondicherry. He is also the fellow of Indian College of Hematology, and he has about 239 publications and has a very special interest in hematopathology as well as medical education. Today he is again with us and is going to lecture us on a very important topic, that is myelofibrosis, causes and effects. Well, thank you so much. I stop over here. Over to you, sir.
Thank you, everyone, and thank you, Amit and Dr. M.B. Agarwal. I'll share my screen. And Amit, it's not going to be a lecture. I hate lectures. I was always a backbencher. So there'll be no lecture around for now. One sec. Yeah. Is it visible?
Not yet, sir.
Not yet?
No.
1 second. Better now?
Yes, it's visible now in the full screen mode. Perfect, sir.
Yeah, so I'll start. Today's discussion or topic that I'll speak on is myelofibrosis, causes and effects. And at the outset, I would like to thank my PhD scholar, Dr. Srirag, who has not just helped me with the presentation, but also has been a part of my journey into myeloproliferative neoplasms and CML, and he has done a good work in this field. So this effort that I'll be doing will involve Srirag's contribution as well. All right, we'll start the thing with something little trivia and little fun. What do you call someone who has 5 brothers and 5 sisters? It's a WhatsApp joke that's going around. Fibrosis. All right. So with that, let's start. And on a serious note, what is in store for all of us? In the next maybe 40-45 minutes, we'll discuss a bit about the microenvironment of the bone marrow, talk on the pathogenesis of fibrosis in the marrow, differentiate between reticulin and collagen fibrosis, grade myelofibrosis, and then, as usual, what I do, we'll have lots of cases to discuss where fibrosis has played a major role. Usually what I do is I start with the cases, but here I thought I'd do a bit of theoretical stuff because bone marrow microenvironment is something so interesting and something that many of us are not really aware of. In fact, this is something that I have recently been working on and realized that there is a lot of things to learn, to understand before we go ahead. All right. So what is this bone marrow microenvironment? It is a dynamic functional unit arranged in an organized framework which surrounds and nourishes the hematopoietic cells. And this is composed of several different cell types, cytokines, chemicals, and a matrix protein that is essential for the proliferation and differentiation of the hematopoietic stem cell and the progenitor cells. And this microenvironment in the bone marrow, these hematopoietic stem cells are localized to restricted areas of the microenvironment in the marrow. And these are called the niches. It's not spread uniformly all over. It's in pockets and called niches. And broadly speaking, there are 2 kinds of niches for the hematopoietic stem cells, the vascular niche and the osteoblastic or the endosteal niche. The hematopoietic cells which are located in the vascular niche are those that play a role in the proliferation and differentiation of the cells, whereas in the endosteal or the osteoblastic niches, they are the hematopoietic stem cells that are the quiescent one, which helps in maintain the pool of the hematopoietic cells. Right. So there are 2 different, they're not really very different, but they are related to each other. And this is a cartoon which again Srirag has made himself. So this kind of explains. If you look at the bone area, the osteoblastic cells are there, and this is the area where the osteoblastic niche is there. This is the area which is relatively low in oxygen, but this is where the quiescent hematopoietic stem cells say. And there are a whole lot of influences, starting from the nerves to the various chemicals, various cytokines, We'll talk about some of them in slightly more details. The other niche is perivascular. It's around the sinuses where the basic proliferation and differentiation of the hematopoietic stem cells take place. So what are these stromal cells? They could be the basic mesenchymal stem cells, the vascular and sinusoidal endothelial cells, or the pericytes, the fibroblasts and the fibrocytes themselves, macrophages, dendritic cells, lymphoid cells, the fat cells, osteoblasts, osteoclasts, chondrocytes, neuronal, and even glial cells are there in the marrow, which all form the microenvironment of these niches. The matrix provides the general framework of the niche and anchorage sites for the hematopoietic stem cells and also the stromal cells. They are produced by these stromal cells and consist of glycoproteins, proteoglycans, and different type of collagen, mainly the type 3 collagen, which is reticulin, and type 1 in times of stress and other times. We'll discuss that. Fibronectin, laminin, and other host proteins are also present. Of the cytokines and chemokines that play a role, TGF beta, transforming growth factor beta, is very, very important, plays a crucial role in fibrogenesis, but there is an equal amount of contribution by the other fibroblastic growth factors, platelet-derived growth factors, VEGF, the BMPs, bone morphogenic proteins, and other cytokines. While these are responsible for laying down whatever little of basement membrane, the fibrogenic things, there are also an equal number of matrix metalloproteases which help remove the laid down collagen that is taking place. So there's a concert between the fibrogenic factors and also the ones that remove the collagen. So that interplay is very important. Just a few words about something called a blood-marrow barrier. I mean, if you understand this, you will understand why the various manifestations of fibrosis takes place. There is like a blood-brain barrier, we have a blood-marrow barrier. It's basically a biological structure formed by the bone marrow sinuses. Notice these are the sinuses with the arrowheads, the red and the blue, and this is the arteriole, the vasculature, the vessels in the marrow, and there are these sinuses, and that selectively controls the movement of the blood cells, preventing a premature release of immature cells while allowing the mature cells to enter the bloodstream. That's what happens. Why is it that only on maturation, the RBCs or the WBCs, which are mature, come out into the blood and not the other cells? So this is orchestrated very beautifully. There's a tight regulation which is brought about by the endothelial cells. Certain molecular cues like glycophorin on the RBCs is responsible for it to move out. Proplatelets, as megakaryocytes, they exude out of the sinuses. They release the platelet in the form of flow platelets, and only then the platelets move out, and certain mechanical factors. This the marrow-blood barrier is unique. It's basically a sinus which is composed of a single layer of endothelial cell, and there are no other supporting cells to this sinus, unlike any other system, any other place where sinuses have. Something like the hepatic sinuses, the bone marrow sinuses are just a layer of endothelial cell, and the surrounding hematopoietic marrow cells, they support the reconstruction and remodeling of the sinusoidal microcirculation. Why do we go into this? Why am I talking about this? I'll soon describe. And you can highlight the sinusoidal architecture of the marrow by a CD34 stain that often helps us in understanding the angiogenesis of. The hematopoietic stem cells, and again, as I said, the stem cells and the mature cells possess the ability to navigate through the sinuses and come into the peripheral circulation. So you do have a population of stem cells which can move out, and also only the mature cells come out into the circulation. So what is this fibrosis? This fibrosis represents an important structural change in the marrow that interferes with, one, its normal function, interferes with the blood-marrow barrier, and also destroy the stem cell niches. The etiopathogenesis of fibrosis is being understood, not very well, excepting in the primary form. In others, we still have a lot of work to do in understanding why fibrosis takes place. What is normal? What is the normal extent of fibrous tissue in the marrow? Very little stainable fibrous tissue is there in the marrow, which is occasionally fragmented. This is here and there. If you do a reticulin stain, all of us who are familiar with the staining of the reticulin stain, here and there'll be some occasional fragmented reticulin. At times, there is a perisinusoidal or perivascular condensation of reticulin. That's normal. It's very little stainable. Not that there is no reticulin fibers, but what we can stain is very minimal. So fibrosis of marrow is always secondary to a primary event, which could be clonal or non-clonal. One important point to understand is the megakaryocytes and platelets form the central arm in myelofibrosis, but any other cell, whether it's malignant and clonal, non-malignant, infiltrating malignant, metastatic cells, residual marrow cells, immunologically competent cells, all play a role, however, maybe smaller than the megakaryocytes and platelets. And two things happen. Either there is increased fibrogenesis, or there is a reduction in the activity of the matrix metalloproteases that remove the laid down collagen. So either there is increased fibrogenesis or reduction in the matrix metalloproteases activity. So both these together go hand in hand in increasing the fibrous tissue in the marrow. There are certain key genetic drivers we have learned now. Clonal hematopoietic stem cell, the mutations, especially JAK2, increased JAK-STAT signaling, cytokine dysregulation. Again, the TGF beta 1 is definitely involved. It is normal megakaryocytes have 5 to 10 times this TGF than any other cell. And neoplastic megakaryocytes, clonal megakaryocytes have even an increased amount of that. Release of PTGF4, release of other cytokines that inhibit matrix metalloproteins. So this is the basic molecular basis of the pathogenesis. What is the role of the megakaryocytes? Megakaryocytes and platelets, as I said, are directly involved. And those that are JAK2 positive or positive for related downstream or upstream mutations are fibrogenic. Now, what happens? Normally, what happens, the megakaryocytes, as I said, they insinuate into the sinuses and release the platelets. So the platelets don't directly come in contact with the bone marrow structure. But when they are morphologic, normal megakaryocytes, as you know, are located around the sinuses. But in abnormality, either they are morphologically, physiologically abnormal, or there is this clustering where megakaryocytes are present away from the sinuses. What it does is it releases the platelets into the interstitium of the marrow. And therefore, along with the platelets and along with this activation, a lot of fibrogenic growth factors, cytokines, etc., get released into the marrow interstitium. And all that together produces fibrosis. So that is how normally, this is the normal architecture, normal topography of a megakaryocyte. Notice that they are located near the sinuses here. And that's where they directly push out the platelets, and this fibrogenic property is not there. But when they are located clustered in the interstitium, one, they are abnormal. So they may be having more of fibrogenic factors, plus they release all that into the interstitium, leading to fibrosis. Also, if you realize there's something that I have read up recently, the levels of the GATA1 and the GATA2 in a megakaryocyte are different. So there are three kinds of megakaryocytes. One that generally produces platelets, one that are immune poised, that respond to the immunological aspect, and those that are niche poised. The niche poised megakaryocytes are rich in high GATA2, rich in GATA2. And the clonal megakaryocytes that are produced in, let's say, myelofibrosis, etc., are mainly the niche poised megakaryocytes. This group of megakaryocytes, and therefore they are more fibrogenic. Okay, I think enough of theory. Now let's see what is this pathological progression. There is this, I hope all of you know as pathologists, that there are many types of collagen, of which reticulin is the type 3 collagen, and the collagen that forms in bone is the type 1 collagen. Generally, marrow has type 3 collagen, and when fibrosis sets in, there is parallel, not necessarily sequential deposition of type 3 and type 1. It's important to know what kind of fibrosis is it, whether it's reticulin fibrosis, because reticulin fibrosis may respond to early intervention. Collagen fibrosis is associated with severe marrow dysfunction and therefore is kind of an irreversible process. So just a few words on how to differentiate reticulin versus collagen. You know that reticulin fibers are thin, collagen fibers are thick. Reticulin is composed of type 3, collagen is of type 1. You use the silver impregnation. Usually we use the Gomori silver method to demonstrate the reticulin, whereas for collagen, you need the trichrome staining. As I said, it's often reversible, less advanced, and has a better prognosis, the reticulin fibrosis. It's important whenever we are staining the marrow for reticulin or for trichrome, we need to know which of the type of collagen is getting stained. So when we grade myelofibrosis, it's important, all of us who are doing bone marrow trephines, it is important that you always add a reticulin and trichrome stain to grade the fibrosis for whatever be the reason you're doing it. The current is the European consensus system of 0 to 3. This has replaced the earlier scales like the Bauer Master, which were more confusing. That's why it has got replaced. Has an improved reproducibility, and it's based on the density of reticulin, the distribution pattern, and it's a kind of a semi-quantitative assessment. And as you all know, we do the Gomori Silver for reticulin and Mason Trichrome for collagen. So if you, I'll show you the cases. Fibrosis has always to be assessed in cellular areas. Okay, don't pick up an area where there is a lot of fat or hemorrhage or something procedural hemorrhage. There, don't grade the fibrosis. As I said, the left panel is the Bauermeister. The right panel is the European consensus, which we practice using now. So how is it? We report it out as marrow fibrosis grade 0, which is normal, where there are scattered linear reticulin. I had shown this slide earlier. There are no intersections, and this indicates absence of fibrosis, and this is normal. Okay, it is grade 0. It has to be just very fine fibers here and there. Grade 1 is mild fibrosis, where there is a loose network of reticulin fibers. There could be new intersections, but particularly perivascular, but there has to be no collagen, and this kind of fibrosis doesn't really impact the hematopoiesis. There's minimal impact of hematopoiesis. There are thin, may have intersections, but very thin fibers, and it's loose. The myelofibrosis 2 is more diffuse, more dense, extensive intersections, and may have collagen, may even have osteosclerosis, but not diffusely. And this kind of fibrosis is bad. It's increased and has moderate impairment of hematopoiesis, right? So MF3 is severe fibrosis. So there is coarse collagen fibrosis. So on a reticulin stain, you will find almost blackish colored areas with thick fibers. Should have a lot of collagen fibrosis. That's collagen. That's when you do a Mason trichrome. Blue color is the collagen fibers. This also may have osteosclerosis, bone remodeling going on in the fibrotic areas, and this severely reduces hematopoiesis, is seen in advanced stage disease, and has a poor prognosis of the three. So generally, we must train ourselves to identify grade 2. At many times, whenever we do a bone marrow biopsy, along with the H&E, we do a reticulin and a trichrome. But at least if you just do reticulin, all cases of grade 2 on reticulin must be accompanied by a trichrome to see whether collagenization is formed. Because as I said, collagenization is poor prognosis. So let us see, this fibrosis occurs in certain stages, and all that can be identified in a marrow. Sinusoidal dilatation, a lot of angiogenesis takes place, fibroblastic proliferation, fibrosis, overt fibrosis takes place, and then neo-osteogenesis sets in. So this is kind of a spectrum that happens. So what does this fibrosis cause? This fibrotic marrow reduces, therefore, the hematopoietic space. There is also chronic inflammation. There is neoangiogenesis and neo-osteogenesis in the marrow. And all this leads to signaling of start of extramedullary hematopoiesis in the spleen and liver. And understand that in spleen and liver, there is this marrow-blood barrier is not there. So whatever hematopoiesis is taking place in the spleen and the liver come out into the circulation. And that's why you get what is called leukoerythroblastic blood picture. So this effect of myelofibrosis, all these three, reduced hematopoietic space, distorted blood marrow barrier, and the extramedullary, leads to clinically most of these patients, when they have a high-grade fibrosis, pallor and splenohepatomegaly. Usually the spleen is bigger than the liver, but both are enlarged. And in the peripheral blood, you get leukoerythroblastic picture. When it is extreme, you can get pancytopenia. So what is leukoerythroblastic picture? The teardropping of the RBCs, nucleated RBCs, left shift in the myeloid cells, even up to an occasional blast may be seen. So when you have this leukoerythroblastic picture in the initial stages, the counts may be high, the TLC may be high. Progressively, it becomes pancytopenic. So whenever you're encountering a pancytopenia case in the peripheral blood, if you find NRBCs, if you find metamyelocytes, myelocytes, etc., you know that the cause for pancytopenia is not aplastic anemia. So that on the peripheral blood, you have a fluke. If you find these left-shifted leukoerythroblastic blood picture, it's possibly an infiltrative disorder in the marrow that is causing your pancytopenia. So that is one thing that we must always understand, the juniors who are there. Whenever you're looking at a case of pancytopenia, if you find immature cells. It is not, aplasia is not, the marrow is not aplastic. Marrow has some problem with it, some infiltration. What is also the another important clinical implication, as the more and more we are understanding, this epigenetic regulation is getting increased attention, and targeted therapies can be started. One of them is ruxolitinib. You know, it's against JAK2 signal, JAK2 stack, and JAK2 leading to increased megakaryocytes, increased transforming growth factor beta, increased fibrosis. So we are now going to target the myelofibrosis that is taking place. So what are the conditions where fibrosis sets in? It's a long list. You know, there could be hematological disorders and even non-hematological. So neoplasms, the prototype is primary myelofibrosis. So that's the primary condition. All others are secondary fibrosis occurring in marrow. CML of the myeloproliferative, PMF, primary myelofibrosis, and CML generally has, of course, myelofibrosis has fibrosis. A certain percentage of CML also at diagnosis has fibrosis. The spent phases of polycythemia vera and essential thrombocythemia also presents with fibrosis. Myelodysplastic syndrome can have fibrosis. Hodgkin lymphoma has fibrosis, and that fibrosis in Hodgkin is usually focal, limited to the areas of the infiltration, and is more often fibrosis is seen in Hodgkin than in non-Hodgkin lymphoma. AMLs, particularly M7, uncommonly in ALL or in adult T-cell leukemia lymphomas, we may have fibrosis. Hairy cell leukemia is a prototype of fibrosis, but only reticulin fibrosis. I'll come to that in a while. Myelomas show fibrosis. The non-neoplastic hematological conditions, PNH, gray platelet syndrome. These abnormal gray platelets, the megakaryocytes are rich in transforming growth factor beta, and therefore one of the complications of gray platelet syndrome is myelofibrosis. Certain drugs and thrombopoietin receptor agonist toxicity. The other causes of myelofibrosis, non-hematological, could be infectious, endocrine, autoimmune, or miscellaneous. In the infections come tuberculosis, HIV infection, leishmaniasis, not so much, but yes, at times you do get. Amongst the endocrine disorders, hyperparathyroidism could be primary or secondary, vitamin D deficiency or osteomalacia. Autoimmune disorders, especially SLE, but you have also that entity of a primary autoimmune myelofibrosis, which may not have started off with an autoimmune disease. It's a primary entity in itself. Amongst the other is, of course, this metastasis generally from solid malignancies, breast, prostate, all of them, gastric, can lead to metastasis. Okay, can lead to myelofibrosis. Few words that some of the fibrosis that occurs, especially in hairy cell leukemia and HIV, collagenization doesn't take place. That's why in a hairy cell leukemia, you generally get pancytopenia, but you don't, and not collagen fibrosis, especially in these two conditions. Okay, so let's see some cases now. A 65-year-old man presents with massive splenomegaly, has pallor of hemoglobin of 4. TLC is still all right. Platelets are 56,000. Now, I have taken out quite a few different cases, not just one, just to highlight the various changes that you can get. So classically, tear dropping, NRBCs, and a blast here and there. Another few more slides. Apart from the nuclear RBCs, immature myeloid cells, you also see very abnormal platelets, giant, bizarre-looking platelets. You can get megakaryocyte fragments, proplatelets, etc., coming out into the field. So this sort of a picture is with a massive splenomegaly in an adult. You're dealing with a myeloproliferative neoplasm, possibly fibrosis. Bone marrow aspirate classically is dry. Classically is so fibrotic in extensive myelofibrosis, you do not get a good tap. And the biopsy shows stages of primary myelofibrosis you'll be aware of. But whatever it is, initially it is cellular. Initial stages are cellular, but you notice this, there are lots of megakaryocytes abnormally located, clustering of megakaryocytes, and notice this kind of streaming effect that is there on HLE. Okay, that's very typical of myeloproliferative disorders, especially myelofibrosis. High power view of the grossly abnormal megakaryocytes, very hyperchromatic megakaryocytes are there. Another field showing gross abnormal megakaryocytes. At times, there is a lot of sinusoidal. This particular case, it's a kind of an uncommon finding, but I did get this. There's this very, very prominent sinusoidal dilatation. The fibrous bands are keeping the sinuses open. And this was one case where the sinuses were filled with megakaryocytes, grossly abnormal megakaryocytes. You do a reticulin stain, it's obviously grade 3, and you have collagen taking place. At times, the collagen could be very glossy and extensively involved. CD34 may be done if you are looking for clusters of blasts. CD34 would highlight your sinuses, and there are the CD34 interesting finding where you see the megakaryocyte inside a dilated sinus. So primary myelofibrosis, peripheral blood leukocytoblastic picture, dilated sinuses and suppressed and increased fibrosis. That's the spectrum that you get. If you look at the classification, you have the bone marrow as an important diagnostic feature. Primary myelofibrosis has a pre-fibrotic stage and an overt stage. In pre-fibrotic, the collagenization may not take place. It is just a grade 1 fibrosis, whereas in overt phase, it becomes grade 2 or 3. And it does not meet, I'm not going into the details of these diseases as such. So in the pre-fibrotic phase of primary myelofibrosis, the aspirate may not be very dry, but you can get these abnormal, large, hyperchromatic megakaryocytes. Okay. So reticulin is not maybe grade 1, but this is typically what you see in pre-fibrotic myelofibrosis. Over passage of time, it becomes more obviously fibrotic. That's the overt phase with dilated sinuses. Another one totally, but notice also amongst these fibrous bands that are going all along, the megakaryocytes are still there, trapped in it. Abnormal, dysmorphic megakaryocytes, collagen stain on a overt myelofibrosis. Then comes bone formation, osteosclerosis, and an overtly osteosclerotic bone marrow, right? So we have another case, a known case of polycythemia, 10 years duration. But 10 years, the patient it was quite some years back. So at that time, only he was on phlebotomy and maybe hydroxyurea initially. But gradually, over the last 1 year, his hemoglobin kept dropping, 6 to 7 grams. Splenomegaly was there. Peripheral blood showed leukocytoblastic picture. And the marrow was cellular, but there were areas where fibrosis had set in, osteogenesis was going on, and trichrome was positive, collagenization. So these are group of spent phase of polycythemia vera, where normally in polycythemia vera, fibrosis is not seen. But as it progresses, especially uncontrolled or not inadequately treated, can land up with extensive fibrosis. And that again causes anemia and morbidity. What about chronic myeloid leukemia? Again, details. You know that, what it is. In a typical chronic myeloid leukemia in the peripheral blood, you can diagnose it. The marrow is generally cellular. An aspirate doesn't give you much information, excepting you can identify the dwarf megakaryocytes. Usually, aspirates are unsatisfactory, does not provide more information, excepting you could do the cytogenetics better. Stromal changes cannot be appreciated. Aspirates are done when there are increase in blasts in the peripheral blood and you're suspecting a progressive disease. The trephine biopsies, if done at diagnosis, shows a very hypercellular, and there are two types of morphology in CML at diagnosis. Generally, it's very hypercellular with myeloid hyperplasia, dwarf megakaryocytes. The other type, in addition to whatever we see, shows abnormality of the megakaryocytes and notice increased fibrosis. This type of CML at diagnosis is called the granulocytic megakaryocytic type. The other type, which has just florid myeloid hyperplasia with scattered megakaryocytes, is the granulocytic type. Now, when we started working on CML maybe about 20 years ago, even I had a postgraduate who did her thesis on that, which we published. This differentiation, the granulocytic and granulocytic megakaryocyte, did have a prognostic value to it. This was in the pre-imatinib era. The granulocytic type progressed towards accelerated phase and crisis more than the granulocytic megakaryocytic type. Once imatinib started, was given regularly, because imatinib also affected the fibrous thing. This distinction blurred. But of late, I have again realized that this distinction may have some. Now we are reaching that area where imatinib resistance is setting in. And recently, my PhD that Srirag had done, we did get, though not statistically significant, again a difference between the progression in the granulocytic type versus the granulocytic megakaryocytic type. Okay, so trephine biopsy in the GM type shows increased reticulin, and therefore this is probably important that we continue to do a bone marrow at diagnosis in CML because it helps us do this. The amount of fibrosis is about 40% you can get in grade 2 or 3. So whenever a biopsy, this is just going away, helps you assess the fibrosis or helps you, and also helps you pick up clusters of blasts in the paratrabecular area in a chronic phase. Okay. Let's move on to another group of conditions. This was a 3-year-old child with Down's phenotype. Easy bruising and fever. Hemoglobin was 7. TLC was low. Platelets were high. And the peripheral blood showed blasts. Okay, now all of you there, it is often a quiz question. The typical myeloblasts. Notice the increased platelets, and these blasts have blebbing. So these are prototype of what are called the megakaryoplasts. Right? The marrow was, though cellular, had increase in the myeloblasts and megakaryoplasts both. CD34 was there, CD61 was there on the immunocytochemistry that we did. It was not a very good aspirate to be able to do a flow, but the trephine was there. Very abnormal megakaryocytes, megakaryoplasts in clusters. CD34 was also positive. CD61 was florid. There are these grossly abnormal megakaryocytes here all over. Reticulin was increased, trichrome was there, so collagen was there. CD34 on the trephine highlighted the blasts. This is the CD34 in clusters. CD61 was all over. CD14, 117, all was there. MPO was not so prominent. And so when we did a karyotyping, this is a Down's baby, apart from the Downs, there was also trisomy 8. So we finally called it as an acute megakardioblastic leukemia in a case of Down syndrome. And as you know, there is a 50-fold increase in leukemias, transient abnormal myelopoiesis, and currently the WHO has an entity of Down syndrome with myeloid neoplasms. So that's another M7 which causes fibrosis. This was a 32-year-old married lady, fever and abdominal pain for 10 days. Again, notice pallor, no hepatosplenomegaly, some lymphadenopathy. She was already transfused. Her peripheral blood showed a few blasts here and there, occasional blasts, not too many, 5% we've got. Platelets were low in a pancytopenic background. Notice there was not much of fibrosis, tear dropping, etc. was not there. Blasts were present. The aspirate was done. Not a very good aspirate, again, because of probably fibrosis that was there. There were erythroid clusters. And here and there, if you look, there were these myeloid blasts, not too many, but we did pick them up, and abnormal megakaryocytes. Okay, these were the myeloid blasts. CD34 was positive, not too many, not more than 20% definitely, but it was there. So this was our aspirate report, kind of diluted, suggestive of an acute myeloid leukemia, 10 to 15%. We were not very sure. So we were waiting for the trephine. So 10 to 15% blast, which was CD34 positive and TDT negative. And so it was just a CD34 was the only stain that we had done. Flow was done. Flow was about 18%, but it came out as AML-M1 with aberrant CD10 expression. The trephine was interesting. It was, again, as you notice, there was this patchy fibrosis, overall hypercellular. There were erythroid colonies. There were myeloid colonies. There were grossly abnormal megakaryocytes. So this was their immature cells in sheets and clusters, which was CD34 positive. Again, paratrabecular localization of CD34 positive. So it was definitely acute myeloid leukemia. MPO was seen more in the mature cells, 33 positive, 117 focally positive. E-cadherin highlighted immature erythroid cells. And in other areas, there were very dysbiotic megakaryocytes. Notice the megakaryocytes, notice the fibrosis that is taking place. And CD61 also highlighted not just the mature megakaryocytes, but also blasts. So reticulin was increased, collagenization was focal, not too much, but definitely grade 2 fibrosis. So the trephine biopsy was hypercellular with panmyelosis, clusters and sheets of blasts, megakaryocytic hyperplasia with altered topography, dysbiosis, erythroid islands, which are E-cadherin positive. The blasts were CD34 positive. CD61 stained the megakaryoblast, etc. So where were we? And there was grade 3 fibrosis. This was an entity that was there in WHO till the last one, called acute panmyelosis with myelofibrosis. It fitted in beautifully. It was an acute disorder, like an acute leukemia. There is panmyelosis and myelofibrosis. Cytogenetics showed both two things, -7, monosomy 7, and idiocentric, dicentric chromosome X. So the diagnosis that we gave out was currently acute myeloid leukemia with myelodysplasia related changes. All right. So that's again another group of acute leukes where fibrosis occurs. So the various acute myeloid leukemias with fibrosis, which can kind of cause diagnostic dilemmas, are NOS has fibrosis about 10%, M7, MDS related changes, primary myelofibrosis cases that go into blast crisis may show extensive fibrosis, and acute myelofibrosis, an entity that no longer WHO recognizes. We move on to another 69-year-old woman. She was generally admitted for surgery, but detected to have a macrocytic anemia. There was nothing specific in the peripheral blood excepting macrocytosis. Platelets were, however, adequate. The bone marrow aspirate showed, I'm sure you can pick it up, the monolobed bilobe megakaryocytes, micromegakaryocytes. The biopsy again showed clustering of these cells. Abnormal bilobe, trilobe, monolobe megakaryocytes, small in size, very round-shaped megakaryocytes. CD61 was positive, reticulin was increased. Notice the reticulin fibers surrounding the megakaryocytes. This was a 5q deletion syndrome with fibrosis. Uncommon in 5q deletion, but a certain group of myelodysplastic syndromes can have fibrosis. In fact, there's a current entity of MDS with fibrosis. 10 to 20% of MDS can also present with fibrosis. And these group have moderate to severe, those that have, is closely associated with multilineage dysplasia, transfusion dependency, severe cytopenia, and overall inferior survival. Fibrosis also is more in the cases of therapy-related MDS. You get a lot of fibrosis. We have a 59-year-old male, backache and severe anemia. We are moving on to a different group of disorder. Again, notice cytopenias, leukoerythroblastic blood picture with a shift to left, NRBC is present. And when you do the bone marrow, in that case, you find this small clusters of metastatic adenocarcinoma. Larger areas. Notice this beautiful adenocarcinoma cells in clusters, and also there is an osteoclast signaling that there is something going on in the marrow. It's an elderly. And this was the typical bone marrow with extensive fibrosis and glands trapped in it. Another side which showing even neo-osteogenesis, fibrosis and entrapped glands. PSA was positive in this gentleman, and we diagnosed a metastatic prostate cancer. This 85-year-old lady, she was a CA breast patient 15 years ago, now presented with pathological fractures and lytic lesions in the pelvis. And thought was, has she developed a myeloma? Again, she had hemoglobin low, TLC was high, platelets were low, and anucleated RBCs and leukoerythroblastic blood picture. Lots of NRBCs, 24 of them. And the aspirate showed glands, malignant glands, which were ER-PR positive. And look at this extensive fibrosis caught up in which they are there. And also look at the bone. That's why she had lytic lesions. There's a lot of osteoclastic activity, bone resorption going on. That is why she had lytic lesions and bone pain as a presenting fracture feature. Again, extensive amount of collagenous fibrosis. So this was 15 years ago, CA breast, now presented with metastasis to the marrow. So tumors that metastasize to marrow could be anything. This was a follicular thyroid. This is a signet ring carcinoma. There's another gland adenocarcinoma, I think, from colon. So all of these, including small cell carcinomas in the lung, melanomas we have seen cases, and the round cell tumors, can also do in the adult. So we had 2 publications that we have got. This was, in fact, actually my thesis. We had a study of micrometastasis in breast cancer. 11 of our patients had bone marrow involvement, of whom 4 had leukoerythroblastic blood picture, and all of them had increased fibrosis. Similarly, in another study of our cases with 23 patients with leukoerythroblastic picture, the 6 of them had leukoerythroblastic picture, and all 6 had grade C myelofibrosis. So that just goes to say myelofibrosis, high grade, leukoerythroblastic picture, anemia, cytopenias, and the prognosis is poorer. Same thing in a 3-year-old boy. Leukoerythroblastic picture, shift to left, including blast. So this at times will confuse you. Are we dealing with an acute leuke or not? The marrow shows clusters of small round cells. You can make out the neuropil, small cells surrounding it. So that was morphologically a beautiful case of neuroblastoma, round cell tumor. This was the trephine biopsy. Again, notice the crushing and the amount of azopar defect, the fibrosis that is going on. The neuropil is visible. You do a stain like synaptophysin, neuron space, whichever stain, and you diagnose metastatic neuroblastoma. So this is one of the common tumors that spreads to the marrow. Approximately 50% have marrow involvement, and this is of a prognostic significance. This is a 2-year-old boy, mass in the orbital region, neck nodes were positive. Again, we thought of it as, are we dealing with a leukemia? No. But the marrow showed this. Anyone? Typical tadpole cells of an embryonal rhabdomyosarcoma. Desmin was positive. This was the biopsy. Again, notice the extensive amount of streaming that is going on and a rhabdomyosarcoma. So marrows that, the tumors, childhood tumors that metastasize also generally produce a lot of fibrosis. And there could be anything from the round cell tumors like neuroblastoma, Ewing's, rhabdomyosarcoma, rarely medulloblastoma, Wilms retinoblastoma. And their differential diagnosis, because they are round cells, to many of us is often a leukemia lymphoma. Are we dealing with it? Without a proper history, you may land in this pitfall. Let's move ahead. A 40-year-old man, lethargy, abdominal pain, multiple nodes. Ultrasound had multiple abdominal nodes. Because of the cytopenias, before the node was sampled, a bone marrow was done. And this was the bone marrow. Again, a lot of fibrosis, hematopoietic cells in a disarray. And here and there, you see these large cells, right? Can you spot them? Let's look at them in a high power. Prominent nucleolus. A binucleated cell, do a CD30, and you diagnose Hodgkin lymphoma. So Hodgkin lymphoma is notorious for causing focal fibrosis. It's not diffuse. It's not anywhere. Notice this. This is the area where fibrosis is taking place. And this is the reason why in Hodgkin lymphoma, aspirates often don't give you a good yield of Reed-Sternberg cells because they elicit so much of fibrosis. In fact, I think in my last experience, I've yet to see a good classical Reed-Sternberg cell in a bone marrow aspirate. The one that I have seen is, of course, one of my very dear resident had picked it up. This was on an imprint, Reed-Sternberg cell. And it's basically bone marrow involvement is seen in 10%, mainly the nodular sclerosis type, which we have seen to be involving the marrow. At times, it's an incidental diagnosis. Fibrosis and necrosis both are there. Aspiration yield is poor. In our report of 76 cases of Hodgkin's, 14 having involvement, none of them were detected on the aspirate. And many of them, again, present with cytopenias, leukoerythroblastic blood picture, and with grade 2 to 3 fibrosis. Okay, a 70-year-old man, easy fatigability, big spleen, pancytopenia, with a lymphocytic preponderance. Your diagnosis is made on the peripheral blood. Look for hairy cells, right? The bone marrow aspirates are often diluted, and hairy cells have this typical pericellular kind of reticulin fibrosis. Okay, this is like what is called the chicken wire or the fried egg appearance. And this is the pattern of fibrosis that you get in hairy cell leukemia. CD20 and you diagnose it, right? So the 45-year male, who is an interesting case, presented with hepatosplenomegaly. Provisional diagnosis, clinical diagnosis was CML, but the counts were not like CML, 4.5, 10,000 only TLC, platelets low, and the peripheral blood again showed tear dropping, typical leukoerythroblastic blood picture. And we also found here and there an occasional plasma cell. Okay, so we were wondering, hepatosplenomegaly is not a common presentation of multiple myeloma. Bone marrow aspirate showed plasma cells, lots of plasma cells, binucleate, plasmablastic. Notice this, very prominent large cell, prominent nucleolus, 65% on the aspirate. Trephine biopsy was packed, showing very plasmablastic morphology of plasma cells with very prominent nucleolus, increase in marrow fibrosis. CD138 was positive, lambda light chain positive, and we went on to diagnose a multiple myeloma. Now, the cause for myeloma with hepatosplenomegaly, is it really fibrosis? Maybe fibrosis, but whenever you get such a case, always think of amyloid deposition. That's another thing that may cause organomegaly in myeloma. So our study also we have with Rajiv, I had done plasma cells, again, for myeloma. Because of this fibrosis, at least 20% of cases have fibrosis in myeloma. Your aspirate may underestimate the plasma cell burden. So it's always good to do a trephine biopsy. And as again, whenever there is fibrosis, cytopenia and leukoerythroblastic blood picture was more prominent, and it correlated with the poorly differentiated morphology, mitotic activity, and the lower median survival in myeloma. So fibrosis again has prognostic significance. Here we come across with another 50-year-old gentleman whose only presentation was a non-specific lower back pain. He had eosinophilia in the peripheral blood, and otherwise not much of the TLC and platelets. Even his hemoglobin was 12, but peripheral blood showed a shift to left with NRBCs. ESR was not raised. I mean, because of his back pain, there was no M band, but there was lytic lesions in the pelvis and L3. Aspirate was not very good, but it showed mast cells. Focal clustering of mast cells, high part. Notice the streaming, notice the cells. On closer magnification, extensive amount of fibrosis is going on. And toluidine blue was positive, CD117 positive, tryptase positive, and we diagnosed a mastocytosis. So mast cells are known to cause fibrosis in the marrow. Some non-neoplastic cases, and we'll wind up, a 3-month-old baby with massive hepatosplenomegaly. Clinical suspicion, this case I have shown many a times before, earlier also in many situations. Storage disorder, again had a leukoerythroblastic blood picture. Aspirate was absolutely dry. And this was the bone marrow. Bone marrow showed cartilaginous, helter-skelter arrangement of the cartilage, extensive amount of bony trabeculae being present, lot of osteoclastic and osteoblastic activity. Okay. Another one. Notice the very abnormal mineralization, abnormal calcification, the kind of serpiginous way the bone trabeculae, bony matrix is going into the marrow. So the diagnosis, osteopetrosis. This particular slide, I thank Dr. Narasimhapriyan, one of my juniors. He sent me a case of osteopetrosis, an excellent slide which he diagnosed. Thank you for this. And you do an X-ray and you diagnose osteopetrosis. So it's a marble bone disease, rare, but it results in infantile anemia, hepatosplenomegaly, and often with extensive fibrosis and bone formation in the marrow. A 20-year-old girl, fever for 1 month with multiple cervical lymph nodes, cervical, inguinal, etc. And the FNAC was reactive. She had cytopenias again, hemoglobin 7, indices were normal, TLC 2300, platelets low, normocytic normochromic, leukopenia, but this did not have much of fibrosis. So much of tear dropping, no NRBCs, etc. Just pancytopenia. Bone marrow, so it was done, indication of cytopenia. Normal marrows, not a very cellular good marrow, but my very diligent resident picked up LE cells. These are the LE cells, neutrophils with phagocytosed nuclei bound by the immunoglobulins. Okay. And we labeled it as a reactive marrow with presence of LE cells, advised to investigate for SLE and other connective tissue disorders, which was positive. So SLE induced, the biopsy was non-specific, but showed fibrosis. We did not get hematoxypal bodies that we were looking for. Lymphocytes, plasma cells were increased, but it showed almost grade 2 fibrosis. And another entity, that is the autoimmune myelofibrosis, without a background of a connective tissue disorder, the primary autoimmune myelofibrosis, we are getting a few cases which shows this fibrosis, unexplained cytopenias, fibrosis in the marrow. Otherwise, the marrow is not very much involved. And you do the antibody titers and they come positive. I think this should be this is a 60-year-old retired bank officer, known case of a chronic kidney disease on regular hemodialysis. Had refractory anemia and his hemoglobin would not move off from 4.5 to 5. He was on erythropoietin, received multiple transfusions, and he had generally pancytopenia, but generally anemia. Okay, the TLC platelets were okay. There was no shift to left, no tear dropping, no NRBCs. It was just an anemia. And the bone marrow aspiration was done. It was normocellular, not a very good aspirate. The biopsy was interesting. It showed us features of what is called the renal osteodystrophy, a scalloped trabeculae, increase in paratrabecular fibrosis. Increase in paratrabecular fibrosis, you do reticulin stain, collagen stain, and they are positive. Lot of osteoclastic activity, and this is renal osteodystrophy. Again, another slide. This is not my slide, but Tejinder Singh's case. Nice osteoclastic activity. This is how it looks. So the last case that we come across fibrosis is a 45-year-old man. Fever, low grade for 3 months. Investigation for fever was negative. So the indication of doing a marrow was PUO. Again, there was not much of a change in the peripheral blood. Mild anemia. Anemia was there. Leukopenia was mild. Platelets were mild. Bone marrow aspiration was kind of reactive. ME ratio was 3:1. And this was the defined biopsy. Granulomas. Focally, there was caseation. So we picked up AFB was, of course, negative. We called it tuberculosis. What is interesting about this is this beautiful reticulin condensing around the granuloma. So one thought was sarcoid, but there was definite caseation in one of the few of the granulomas, and the patient did respond to ATT. So to summarize, myelofibrosis has varying etiology. There's an interplay between the megakaryocytes and platelets, the mesenchymal cells, and the various cytokines, especially TGF. Could be clonal, could be non-clonal, but whatever it is, fibrogenicity is imparted mainly by the megakaryocytes and cells. The grade of fibrosis is important. For all of us who are looking at the marrows, the pathologists among us must try and grade not just try, should grade the fibrosis, because that determines the clinical behavior and the outcome. Increase in anemia. It's more patients present with anemia, presents with cytopenias. Their prolongation, they are less amenable to therapy. Leukoerythroblastic blood picture is often seen with advanced fibrosis, and whenever it's important for pathologists to identify fibrosis and hence elucidate the cause of fibrosis. All right. So these are my references. This first article by Dr. Kanjaj Ghosh and Dr. Shom. Dr. Shom was my teacher. Exceptionally good article on fibrosis. I was really glad that I could lay my hand on it. And all my, whatever I read, whatever I said, is primarily from this article. This is again another very good article. Couple of my own articles, and of course my thesis that Srirag did had a lot of insights into this presentation of mine. Thank you very much, and I'm happy to answer questions. So I'll stop sharing.
Thank you so much, sir. Wonderful talk as always. And you always keep us, engaged in your talk. The way you speak, fantastic, fabulous, sir. And now I request all our discussants to please put the hand raise sign so that we can start our question session with Dr. Basu, sir. Yes, Tara Roshni Paul, ma'am, your question, please.
Good evening, sir. Lovely talk. I have a question about the autoimmune myelofibrosis. The secondary one, I mean, we suspect myelofibrosis as pancytopenia. You get a bit of grade 2 reticulin and above in the marrow. Some lymphocyte aggregates may be there which turn out to be reactive. The ones that are associated with SLE or rheumatoid or something, we can say that. But if that is not there, is there anything to be sure and call it autoimmune myelofibrosis?
I suppose it becomes, no, I don't think so. It becomes more of a diagnosis of exclusion. You exclude
Exclusion.
out all the other causes. And then if you are left with nothing else, you label it as primary autoimmune myelofibrosis. I don't think there's any specific antibodies that is a part of primary autoimmune. It's probably some secondary which we are not able to pick up. That's what I take it. Anything is you have to differentiate it from other causes of myelofibrosis because these generally respond to steroids.
Steroids.
So
That's why it's important.
that's why you have to be sure that it is no other type of myelofibrosis that is occurring in the marrow. So
and
that's how
another
I
one
look at
question,
it.
sir, regarding
Yeah,
the
sure.
changing from 4 grades of reticulin fibrosis to 3 grades. Do you think it was right? Or I feel sometimes there are some grayish areas. I actually prefer the 4.
There will always be gray areas, but I think it is better with 3 grades, 0, 1, 2, 3. Because in the earlier one, the Bauer master that we used, that 0 and 1, both were said to be normal. It was very difficult to really say which is 0 and 1, so that was one reason. And the fact that currently they say that in grade 2 also you can get mild mild osteogenesis and collagenization is there. If you realize in Bauer master, osteosclerosis was not a part of the grading at all.
Yes.
It was only limited to collagenization. But we have seen that many of the cases with extensive myelofibrosis do show bone remodeling. So I somehow now prefer this one. Maybe it's because it's easier, 1, 2, 3 instead of 4. So, but I think this is slightly better. There'll always be a gray zone areas, where you're not sure whether it's 1 and 2. But at least 2 and 3, you should be able to, pick it up. And that's important.
Thank you, sir.
Thank you, ma'am. Dr. Amrita, ma'am, your question, please.
A wonderful talk, sir. I mean, we really enjoyed the pictures and the beautiful case studies you have shown us. So my question was like, when we see morphology of the bone marrow biopsy and we find megakaryocytes with atypical or abnormal morphology, but when we do molecular studies and we don't find any clear driver mutation, and there is no significant clinical feature, so how to classify such a case when there is no clear-cut driver mutation? That's what I am wondering.
I know. We do get such cases, but only thing we have to be very sure that those megakaryocytic dysbiosis is actually dysbiosis, or is it, megakaryocytes, suppose by chance your bone marrow is a bit crushed, or it's a very hypercellular marrow. And so the megakaryocyte may look abnormal. So
Yeah.
we have to be first very, very sure that whether it's really dysplastic megakaryocytes or is it just a reactive change that is happening. And many a times in tuberculosis or in Hodgkin's, the megakaryocytes, especially in the periphery of the infiltration, can look abnormal. So that is one thing we have to be very, very sure of. And if there is no driver mutation or anything linking it to a myeloproliferative neoplasm, then I think let us err on the side saying that these are possibly reactive.
And so another point I want to know that, like, when there is triple negative fibrosis and we have a doubt whether it is triple negative PMF or something else, how much do you believe on the morphology and NGS workup for such cases?
I suppose we have to believe, if you look at the classification or of primary myeloproliferative, the megakaryocyte morphology is number one in all the amongst all the criteria.
Yeah.
So if you're sure about it, and it could be a triple negative, you apply NGS. Currently, there's been also some study about looking at the JAK-V612 in the megakaryocytes.
Okay.
Identifying them. I had done one thesis, not very successful, of calreticulin in megakaryocytes, and we did find calreticulin mutated in the megakaryocytes and in the essential thrombocythemia cases. So maybe such things could be done. But if you're sure about your dysbiosis, that's why I said it's important to look at the marrow carefully.
So because many a time there's a lot of overlap in different.
Yes, definitely. There's a lot of overlap.
So it may be
even with the
confusing.
current classification between polycythemia vera spent phase and myelofibrosis and essential thrombocythemia and the cellular phase of myelofibrosis, there can be a lot of overlap.
Right.
It is.
Thank you, sir. Yeah, I understand. Thank you.
Thank you, ma'am. Somebody
Thank you.
Somebody from iPhone? Anybody name iPhone?
iPhone, you just introduce yourself, please.
Okay.
Ramesh.
Dr. Ramesh, yeah.
Sir, good evening, sir. It was a very wonderful talk, and the case studies were very nice. So it's an extension of what Amrita ma'am was asking. So currently we have few patients who are having a very huge spleen, and they have myelofibrosis reported in the marrow, showing grade 3 fibrosis, pegocristial dysplasia. And but the driver mutations are negative. I just did an MPN panel for these patients. It is negative. And I'm currently treating her, like, she has severe pancytopenia. So I'm treating her with prednisolone thalidomide. So to be do you advocate doing an NGS in all patients
Yes,
of
I suppose
myelofibrosis
so.
rather
In such
than just
situation,
MPN panel?
No, I suppose in such a situation, an NGS would be useful. If you're saying it's triple negative, but otherwise there is all the evidence of a myeloproliferative, especially myelofibrosis, I suppose we would like to look at maybe some other driver mutation or other that NGS would help, I suppose, in such situations, definitely.
If cost is not a constraint, then NGS should be done in all patients of myelofibrosis, I suppose.
Not in all cases, maybe. If the cost is not a constraint, then yes. But otherwise, let's rationalize. In some situations where we are stuck at not getting the driver mutation, then maybe yes, why not? In such situations, yes, it would be useful.
Okay, sir. Thank you.
Thank you, Dr. Ramesh. There are some questions from the audience. Dr. Ifat wants to know that is desmoplasia and fibrosis the same? And if especially in the cases where bone marrow shows metastasis?
Yeah, desmoplasia by definition is increase in fibroblastic proliferation. There are fibroblasts, but that's a earlier stage. Yes, my thesis was on bone marrow metastasis in breast cancer. So we did find cases where there was desmoplasia, that is fibroblastic proliferation, but that soon progresses to a fibrosis. So desmoplasia can be picked up by reticulin, not so much by collagen. So it is an extension. It's a once desmoplasia is that initial phase which we say tumor-induced desmoplasia is there, but there it is more of young fibroblasts which proliferate, following which fibrosis sets in. So it is just an extension of this. I would rather use the word fibrosis in bone marrow rather than using desmoplasia. Desmoplasia is better restricted to the primary site of the tumor.
True. Thank you, sir. Dr. Tara, ma'am, any other question you have? Dr. Tara Roshni Paul, ma'am?
Sorry, I forgot to lower it.
Okay. Somebody from iPhone, yes?
Yeah, I'm muted. Yeah. Hello.
Yeah.
Unmute. Hello.
Yes, we can hear.
Please carry on.
Can you hear? Yeah, I'm Dr. Savitri from a pediatric institute. So we are getting cases for fibrosis. Other than leukemias and metabolic disorders, we had come across 2 or 3 cases where patient presented with cytopenias, either single or multiple cytopenias with hypocellular marrow and fibrosis. And later on, when investigations were done after having ruled out all other causes, we found that it was Warshall hemodiaphyseal dysplasia. So we had also not seen earlier. So I would like to just add that when we are talking about fibrosis, this is also one entity which should be kept in mind, especially in pediatric setup. Yeah, that's what I want to add.
Fine. Thank you.
Yeah, most welcome, sir.
Thank you. There's one question which has come up from Dr. Emon Tent. If you get myelofibrosis in a case of chronic myeloid leukemia, is it reversible with treatment?
Yes, if it is reticulin fibrosis, it is reversible, because when we done the study, I had another thesis during the time of imatinib. I worked on CML when imatinib was just started and our patients started receiving it. We did a post-treatment marrow. Now it is not needed, of course, but that time, since we were not aware, we used to do a end of treatment, maybe 3 months a marrow, and we did see imatinib kind of regressing the fibrosis, especially if it was grade 1 or grade 2 at diagnosis, that was getting regressed. But it does. But once collagenization sets in, that is very difficult. Even the TKIs were not very useful in deleting the collagenized fibrosis. That is with imatinib. But with the current second generation TKI, I really don't have much experience. But that we had definitely seen. That's why that differentiation between granulocytic type and GM type, we had kind of omitted. We did not do it. But in the thesis that I did, of course, I did not have a follow-up refine on all the cases. But the progression once did show continuation of fibrosis. But that experience, initial days, imatinib had caused regression of fibrosis. Definitely.
Thank you, sir. Sir, I have one case to discuss with you. There is a patient who is 45 years old female.
Yeah.
It's persistent cytopenia, and this is going on since last 6 months. Patient has moderate splenomegaly. The bone marrow shows multi-lineage dysplasia, very significant, maybe more than 10 to 20%, in megakaryocyte series as well as in erythroid series. And the fibrosis he has is grade 1 fibrosis. Is it okay to label such patient as MDS with fibrosis? Number 1. Or any such entity exists like MDS with early fibrosis?
MDS, as I said, about 20% of MDS can show fibrosis. The entity that WHO talks of is massive fibrosis, high-grade fibrosis. That entity has been there. But yes, we have seen MDS with fibrosis. It is not that it doesn't happen. So there is no harm in calling it. If you have called it MDS based on your cytogenetics and your morphology, there is an entity, even the one that I presented here, that 5q minus, that showed about grade 1 to 2 fibrosis is there. And that was how the patient presented with cytopenia, and that probably splenomegaly was there in that. So there is no harm in not calling it with fibrosis. MDS with fibrosis. Yeah. I'm not sure if there is a word like early fibrosis, but we can stage it. We can grade it like grade 1 fibrosis. It's fine.
With
MDS
grade,
is also known to cause fibrosis. There's no doubt about it.
so if with grade 1 fibrosis also, are we sufficient to call fibrosis? MDS
Yes,
with,
yes. Yeah, if you are following the current classification, the European consensus, only grade 0 is normal. If you see thin fibers intersecting here, perivascular location, it is increased fibrosis. Grade 1 is also increased fibrosis. It's not that it is normal.
Great.
In the current classification, the older Bauer Master, grade 0 and grade 1 were taken as normal. But the current one is, as I said, fine fibers, even if they're intersecting, is to be considered as increased fibrosis. Maybe you can say low grade fibrosis or early, but grade 1 fibrosis is definite fibrosis.
thank you, sir. Anybody has any other question? Because there are no more questions in the chat box.
All right. Saturday evening, I think.
Thank
Let
you so
people
much, sir.
enjoy.
And for the fantastic talk, as always, lovely talk, fabulous. Hats off to you, sir.
Thank you so much.
And all our discussions to join today. Meet you tomorrow at 11:30 a.m. Thank you so much.
Thank you.
I'll leave, right?
Mr. Somnath Banerjee, little vote of
Yeah.
thanks.
Yes.
Okay, fine.
Thank you, Dr. Amit sir. I would really like to thank. Hello, am I audible?
Yeah, yes, you're audible. Please
Yes,
go ahead.
you are.
Yeah, I would really like to thank Dr. Devdatta Basu sir for the right from the first slide where the five they were there for the epigenetic regulations of fibrosis to bioproductive neoplasm and all. So sir actually has briefly described about the topic on myofibrosis causes and the effects of it. And sir is always, sir's lecture always reminds me. So for whether it be the first line of rheumatoid or bottom. I would also like to thank Dr. Amit sir for generating such MHG webinars of such creativity, and we also get a lot of insights from that. With that, I would also like to thank everyone. Happy weekend.
Thank you.
Thanks.
Bye-bye.
Bye.
Bye, sir.